of moderating this next panel, which is going to be about innovative solutions. And this is the one where we're going to really be talking with leaders around, what do interventions look like? What do they look and feel like in community? How do we know they're effective? How would we define effectiveness, right? So Tone Vai is an LCSW from Samoan Community Development Center. Tone is raised on Ramaytush Ohlone territories from San Francisco. And has family ties to American Samoa, where his parents are from. And Tone has really, for the past decade, committed himself to really supporting and delivering comprehensive wraparound care for youth and families, especially those in foster care and children aged 0 to 5. He's a mental health consultant and clinician at the Samoan Community Development Center and provides free therapy to Samoans and Pacific Islanders throughout San Francisco County, collaborates with other staff and community partners to promote community-based mental health outreach and education for folks throughout, for specifically Samoan and Pacific Islander communities throughout the San Francisco Bay Area. So Tone, I will welcome you out first. Second, we have Anni Chung, who is the CEO of Self-Help for the Elderly. So Anni's been the CEO of Self-Help for the Elderly since 1981. Self-Help for the Elderly provides comprehensive services, health, education, social and recreational services to 40,000 seniors across 15 different senior centers in 5 Bay Area counties. So San Francisco, San Mateo, Santa Clara, Alameda, and Contra Costa. In addition, Self-Help for the Elderly operates 3 HUD-insured affordable senior housing projects as well, 2 in San Francisco and 1 here in Oakland. Anni's on a lot of things, but she's on the steering committee of the API Council in San Francisco and is the Elder Abuse Chair of the Family Violence Council in San Francisco. At the state level, she was appointed by the governor to serve on the California Commission on Aging. And in her spare time, she's the producer of a public affairs show called Chinese Journal for KTSF, Channel 26. Anni, welcome Anni out. And last but certainly not least, we have Wang, who is the executive director of Lavender Phoenix. Yuan is a transgender, non-binary Chinese American organizer and the ED of Lavender Phoenix. And Yuan started at, we call it Lavnix for short. She started at Lavnix as a summer organizer apprentice, actually, and then served as Lavender Phoenix's trans justice community organizer, and then became the ED in December of 2021. So the role is really about supporting Lavnix's staff team, sustaining resources for organizing, and really rooting the organizational culture and strategy in the organization's evergreen values. So her community at Lavender Phoenix has taught her what interdependence looks like in practice and reminds her every day to lead with care and vulnerability. So Yuan, I will welcome you out. Thank you all for being here. I know it's a very busy time, so I appreciate everyone spending their time with us today. So how we're going to do this is similar to the last panel. We'll go ahead and we have got some questions for these folks, and then we will make sure to keep some time at the end for Q&A as well. So definitely be thinking about what questions you want to raise. At first, I'm going to ask each of you to, I've said a little bit about your organizations, but let you highlight what you want from your organizations and just give a quick overview of your programs that are specific to mental health. Tone, do you want to start?
Let's go, Tone.
Is it on?
I don't think so.
Hey, welcome, or hello, everybody. And just to clarify in the intro, you did mention my parents. The villages are from our Fitiuta and Ofu in Manua. So I just wanted to share that. So I'm with the Samoan Community Development Center. I'm a clinician, therapist. And that just happened in the past 2.5 years. Our work in mental health has looked like, has existed under the Samoan Wellness Initiative, which has been going on for the past 12 or 13 years. And that work has looked like different forms of cultural practices like singing, dancing, and storytelling as it relates to healing. And it is in the past 2.5, well, since I came on board 2.5 years ago, that we started offering therapy as a service. And then at large, the Samoan Community Development Center is youth and family based, so we offer so many programs for our young people that cultivate connection to our culture as Samoan and Pacific people, as it relates to singing and dancing. And then we have some of those, well, we have plenty of programs. We have case management, we have connection to social services, we have a program for our seniors, and so we really try to hit all of those points of which a family kind of exists. And so that's us at the Samoan Community Development Center. Thank you so much.
Annie, go ahead. Yeah. Is it on?
Thank you. Thank you, Ron. So self-help for the elderly. So we were born in the year of 1966. So that makes us 58 years old. And many people ask me, does self-help for the elderly only serve Chinese elderly? So I said that in the early, probably first 10 years after we started, self-help really focused in Chinatown, San Francisco. And at that time, there were 3 social issues that challenged our founding board to start self-help for the elderly. At that time, we have the highest TB rate in San Francisco, Chinatown. And then we also have a very high suicidal rate among the Chinese elderly. And then we have very, very, very poor condition where people live, the SROs, right? Mostly all the buildings in Chinatown are the single hotel rooms. So those challenges suggested that we need an organization that's focused on the elderly, that don't speak English, very low income, and almost 100% immigrants. And then self-help expanded after the first decade because health services, affordable housing services, and then also a myriad of other issues start to come when the families start to come reunite with the elderly that first immigrated to San Francisco. So self-help now is not just a social service agency, but I would call ourselves like provide a pretty comprehensive range of continuum of elder care services, range from affordable housing to residential care, which is 24-hour, 24/7 housing care and board and care and housing, and also services for the Alzheimer patients. But we also do a lot of health services, housing, transportation, nutrition. You know, many of you probably know that in San Francisco and San Mateo and Santa Clara, we run a lot of nutrition sites and senior meals program. So we're pretty comprehensive in that nature. Yeah.
Hi, everyone. Can you hear me? Yes. Okay, great. I'm going to speak like right into the microphone. I'm so happy to be here with you all. Again, my name is Yuan. I'm the director of Lavender Phoenix. Lavender Phoenix organizes transgender, non-binary, and queer Asians and Pacific Islanders around the Bay Area. And for us, I think really similar to these two amazing folks, we kind of see every single aspect of our work as a solution for mental health needs. We do have aspects of our work, our healing justice programs, our peer counseling programs, which I can share more about, that are directly addressing counseling needs, mental health support needs. But for us, leadership development is also a form of addressing a mental health need. For us, building community spaces where isolated young folks can connect with each other is addressing a mental health need. So I'm happy to share a little bit more about that and excited to hear about y'all too.
So I might have you, oh yes, thank you. Yuan, I might have you lead off then on that next question, which is really around better understanding how your organizations approach mental health, right? You heard from Tony, like you all just started integrating therapy a couple of years ago, right? And so how have your organizations thought about mental health? The other thing I'll just call out too as you listen is these folks really operate on different parts of the continuum, right? I mean, you'll, whether it's crisis and response, reactive, right, response to really protective and preventative services. And so let's start with you, Yuan, on you talked about kind of leadership development. How did you all get into the mental health work? How do you approach it?
That's a great question. So, I'll start. I remember in 2020, we had just conducted our first round of research in our Up to Us needs assessment, which was a needs assessment that surveyed over 200 transgender Asian and Pacific Islander people in the Bay Area about 100 different questions about their lives. And we were spending a day, myself and a lot of our volunteer leaders, looking at the results from the mental health section. And I remember sitting there with one of our members, Junior, and both of us just breaking down into tears, crying. Because we were asking questions like, do you experience severe depression or anxiety on the day-to-day? And over 70% of people were saying yes. And then we moved on to ask, have you ever attempted or considered ending your own life? And over 2/3 of our respondents said yes. These are the mental health conditions that transgender Asians and Pacific Islanders are living in what is supposed to be a safe haven for our people here in the Bay Area. I say that to say, when we moved on, those statistics for us weren't a coincidence. They couldn't have been. Because in every other area, we asked, hey, can you afford the healthcare you need? Most of our folks said no. Have you ever interacted with or been in community spaces with other folks who share your identities? Most of our folks said no. Can you afford your basic needs? Again, no. So for us, when we look at our data, it's very clear that these dire mental health needs, they're not a coincidence and they cannot be siloed. We need to approach them with a comprehensive set of solutions. That's why for us, we've initiated a peer counseling program. I think last year, our incredible Healing Justice members were able to train more than 30 trans API peer counselors and provide free mental health care to more than 50 folks in our community just last year. And we're celebrating the 15th year of our summer organizer program, where we're bringing in a cohort of young folks to learn how to be leaders and build community for the first time. And we also know that our folks can't feel mentally well unless they're safe. So we're starting community safety initiatives to make sure that our folks have ways to keep each other safe and call on support without relying on institutions that maybe they can't access or maybe make them more unsafe. I think that's why we try to approach mental health from all of those angles.
Annie, do you want to go next?
Sure. So when Carolyn invited me and to join this panel, I reflected on all the services that self-help provide, and I say we never considered ourselves a mental health provider. I was kind of a candid and honest with Carolyn. But when I thought about it, mental health is so important in our community, particularly among the seniors, because if you walked up to our senior, and they're not looking well, and then they would tell you that I can't sleep at night, I lost interest, in seeing my family, I have no appetite, for dinners or lunch, I don't even go out. But they would never admit, that they're a little depressed or they're a little anxious or they're just somehow not happy. So for the longest time, self-help have to deal with mental health, but not calling it mental health. And I'm sure a lot of you would resonate with that. Because we don't, for many years, the mental health translation into Chinese is such a terrible translation. We call them 神經病, right? Like crazy people. Nobody would tell you that they have a family member or themselves have mental illness, right? So because of the advance in coming up with really more appropriate translation, now we call it like spiritual health or 精神健康, right, in Chinese. So we try to have our seniors recognize that mental health, just like if you have the flu or if you have a cold, you treat it, right? You go to see the doctor. But not many, I would say 99.9 of our seniors would not go see a psychiatrist or a psychologist. I so resonated with Christina earlier this morning because in our culture, you would not want to admit that you have some mental disorders or mental illness. So how Self-Help for the Elderly integrate mental health into a lot of our existing services is sometimes because there was no other way for us to provide it. Our budget really don't allow us to hire psychologists and psychiatrists. So when I need mental health counseling, I reach out to Christina at RAMS all the time, and used to be Dr. Evelyn Lee all of the time, and now Angela, to be partners with us so that they could then provide us the services, right? Because we're not trained. In the site, we run like 15 meal sites and senior centers, but our staff are mostly very direct services, right? And there's not really a lot of opportunity for us to send them to training. So I work with the National NAPAFIMA, DJ's group, and she came over and actually trained over 30 of our direct services staff who work with seniors every day for them to recognize, whether the seniors have different types of depression, anxiety, some schizophrenia, because a lot of the times the mental health providers would really ask Self-Help to take in the elderly who have some sort of little bit mental illness, I would say, but not serious. But they have nowhere to go. There's no daycare centers enough or enough daycare centers that would help or provide ethnic meals and also bilingual, bicultural activities. So we try to integrate mental health by having our staff trained, at least to recognize and then to refer. But there are only two places for us to refer to, either the county mental health clinic that none of our seniors would go. They would not go because of such stigmatization, right? They don't want to be labeled as a mental health patient. And then the second referral source would be a community-based program like RAMS. But, as time goes on, we have serious crises among our seniors. So we started our intensive case management, and then we got our case managers trained, at least to provide the immediate help, and then very quickly look around. I always complain that there's not enough bilingual therapists and clinicians to really help the monolingual community. And we have to keep looking for volunteers, retired clinicians that would come back to volunteer to talk to our seniors, or we have to find some extra budget to pay for some crisis intervention. Yeah.
I remember, Annie, and when we were talking about this too, of you talking about how, and I think for each of you, just thinking about the effect of the pandemic too, and I remember you saying that seniors' behavior was changing very drastically. So as an organization, you have to innovate quickly to figure out how to respond, right? So I think it's just highlighting organizations who may not be called behavioral health organizations stepping into this space in new ways that meet community where they're at. Tone, I would love to hear from you all, like how, especially with the shift that you mentioned, like, so how are you all approaching mental health and the PI community?
Yeah, well, I would say the only shift is that we now have a therapist.
Okay.
But I guess I could just start with kind of our values that kind of drive us. I'll start with a Samoan proverb that we speak a lot to, and that's ole ale le pule ole tautua. And then that means the path to leadership is service. For me, what that means is that we are service-oriented people. We to care for you is to care for we, right? And maybe our areas of growth are around caring for me is to care for we as well. And it's interesting because I'm a clinician, I'm a therapist, that's my role, right? And yet I find myself wanting to be in many different spaces as it relates to mental health. because as both of you shared, like everything is connected to mental health, you know. And so I know that I could go there and just have a caseload, right, and just sit there one-on-one with each of these folks that decide to come do therapy. And it's always so funny when I get out there and I'm promoting therapy. I'm telling people to come to therapy, but also telling them not to, right? Just like that this is one of many tools that you can access, right? And so I want to speak to the work that has been happening at the Samoan Community Development Center, because it cultivates connection to our islands, our culture, and that is healing work, you know. That is healing work, and we need that work to continue to happen. And so working with the staff to see the connections to healing, to affirm them and let them know that the work that you're doing is amazing, and to keep on doing it, and also just checking in with them as well and saying, hey, how are you doing? What does it look like to check in with yourself, care for yourself, look out for each other as well. And so even as we move further into this work, another kind of proverb or saying that we have been calling upon is te ole va, right? And that means to nurture the space. Va means space, the space between two entities. And to te ole va is to nurture that space, to care for that space, right? And so it's always so important to look at what's in the va, right? And what it looks like to nurture that and care for that. The va is the space where connection happens. And so it's so important that we are thinking and moving in ways that nurture those spaces, whether it be amongst each other, whether it be out in community. And it really speaks to this work needing to be rooted in relationships, and it has to be collective. We have to be looking out for each other. And then I also call upon the both and. You know, it really is a both and, because we see a lot of people in the community really move in service of the community without checking in with themselves. And what we're constantly trying to cultivate is that we need you to be well too. It's I care for you, and how are you doing too, you know? And so the ways that we think about mental health, they have to be collective and not just in a therapy office one-on-one. And I love that. I love doing therapy one-on-one. Let me just say that too. But it's one of many tools and resources that we can use to support the mental health and well-being of our Samoan community, our Pacific community, and just our community at large.
That's beautiful. And Kevin actually also spoke about VA earlier, right? And I think it's...
We love you, Kevin.
So we're getting a double lesson. And Connie mentioned, Dr. Connie earlier also, right? Brought in these themes of like, how do we care for each other, right? Like, how do we have each other's back and support each other? It reminds me too of, you know, it's a very different way of thinking versus a clinical system where you have to advocate for yourself, and it's individual services, like you said, Tone, like in a therapy room one-on-one, you don't have that space around you, right, for healing. I'm gonna ask both Yuan and Tone to talk about the community needs assessments that you both did, because you both did this to kind of inform research, but also then the services you did. And I would love to hear about like what drove that assessment? How did you all do it? What makes it different than, you know, in the health sector, we have health needs assessments left and right, community health needs assessments, and they drive resources, right? It's a different kind of framework. But I would love to hear about like your respective assessments, why you did them, how you did them.
Pass it on to each
It's
other.
okay, you're both gonna talk about it. It's okay, you're both gonna talk, but also, how did you make meaning of them too? So I'll leave it to whoever wants to start.
Okay, I'll go first. Thank you for that, Carolyn. Yeah, so our needs assessment definitely didn't come out of, I think, that more traditional place. It came from, at the end of 2018, we had a collective of our member leaders who were trying to develop strategy for our organization over the next 5 years, over the next almost decade. And we realized that there is just so little, almost no data at the time that concretized the needs of transgender Asian Pacific Islander communities. We were often just a kind of a fraction within larger data that we couldn't even parse out for ourselves. And so we knew that, no one was going to do it for us. We needed to do it for ourselves. So we called this research project Up to Us, because we knew it was up to us, and we launched into it for the next year and a half. I mentioned earlier that we collected over 200 responses from trans API folks in the Bay, but that collection took a lot of work because not a single one of us was a paid and professional researcher. We were coming into it with the questions of, well, we want to understand where our community's at, but do we have the skills to make this happen? And over the course of the year, we didn't just bring people into clinics and ask questions. We went out to Transmarch and surveyed people in person. We held potlucks where we gave every single person a little stipend if they went upstairs with their snack and filled out a survey. We had focus groups where folks who maybe weren't inclined to fill out that survey could join a group of other trans API people and fill it out together and also make connections, have fun, build deeper relationships. These were all ways that we tried to connect with so many of our people. I'll also say that we had to put a lot of thought into how we were going to deliver this information into the world, because we weren't just creating this survey for healthcare professionals, for decision makers, for policymakers. We also wanted to create it to presence our own community in this world. So when we created the final report, rather than just making it a set of data that I think would have been difficult for me or any of our members to really enjoy or feel useful or accessible to understand, we included stories from participants. We outreached to trans API artists in our community and included poetry, included art that reflected their reflections on what they were seeing. And for us, that was a way to say, hey, for other trans API folks who are reading this survey, a lot of this is going to be very difficult for you to see because it is the hardships of your own everyday experience. But the people who made this made it with you in mind. We are your community and vice versa. So those were some of the approaches we took to making that survey, and it ended up underpinning our current strategy around healing justice, community safety, and movement building. Yeah. How about you, Tom?
Let's give a round of applause for that one. That's amazing. Yeah, that's so interesting that what y'all called your research project Up to Us. Right? Yeah, we totally resonate. Kind of with this feeling of wanting to tell our own stories, and we're here in the AAPI space, and we all should know, if we don't already know, about disaggregating the data because it doesn't really speak to the needs of all of our collective communities. And so when we're in AAPI spaces, as Pacifica people, we're often wondering if we're included in that, right? And so it's up to us, to kind of start driving the bus and figuring out what it looks like to do that, to be a part of creating our own data. And we're storytelling people. And so we had reframed data collecting as collecting stories, talking stories with the community. And we called our research, our community-based, it's been so long. This was 2.5 years ago. Community-based research project, something like that. Anyways, but it was called Kapasa Fetu'u. It was named by Leafa, who is here today, in the Tongan language. Yeah, Leafa is over here. Leafa, raise your hand. Kapasa Fetu'u in the Tongan language means star compass. As Pacific people, we are navigating the ocean with the stars, and kind of being remembering kind of what guides us in the work that we're doing. And so that was such a beautiful way to capture how we wanted to do this work. And what we did was we wanted to capture the strengths, challenges, and needs of Pacific Islander youth in San Francisco. And to do that, we talked stories and we surveyed over 300 community-based leaders, caregivers. That means, by caregivers, I mean mom, dad, grandma, auntie, uncle, second auntie, you know. And then we talked to about 200 youth. And we were guided by, it's important for me to name the people that were a part of making this project happen. Sarah Wang King Tanuvasa, Levalasi Loyon, these are Pacific scholars at San Francisco State University who walked us through that whole research project, who broke everything down, who helped us understand what research looked like. We used specific methodologies to collect the data, and it was such a grueling process. It was, you know, to get out there and collect and talk to the people, but it was fueled by our relationships, right? And so there was a team of us that started off very big and then it became very small. And we split up into 3 teams that were folks that would go, 2 or 3 folks that would outreach to the youth, 2 or 3 folks that would outreach to community-based leaders, and then 2 or 3 folks that would outreach to caregivers. And so one of the most interesting things, I know we can talk about outcomes, but there was so much happening in the process of collecting data. And so, for example, when Mama Sil and Cree were designated with outreaching to the caregivers, they came back the next week with like over 100 people already, right? And so they just, you know, they went to people's houses, they brought food. This is like, nobody told them to, you know, bring them food. You know what I mean? We ain't got money for all of that, but that's just kind of how you do that, you know. And they came back and they said, like, I did not expect to be asked, I did not expect talking to parents about mental health and what's happening and with their children to bring up so much stuff in them. We found that a lot of parents were breaking down, crying, feeling a lot of shame, a lot of guilt, a lot of anxiety and worry about what was happening with their children and our young people. And even for Cree and Mama Sil, who were collecting that data, they were just like, man, this is so heavy. You know, and they came back and they said, like, Tone, like, we gotta give them something. I don't think, you know, I told some of them that we got counseling, you know, and in that moment, I had to draft up something to create so that when they go back out there, they could just say, like, okay, thank you for sharing your stories, and here, if you're interested, you can come tap into some of our counseling services. And so, like, that happened in real time, you know, and that was the most, I would say that was the most impactful thing for me from that experience. But we also learned so many other things, and just that the community doesn't, a lot of people had many different versions about what mental health was. And so it became very clear to me that we always need to be defining mental health in a relatable way, in a digestible way. And so that's been implemented across that sort of kind of basic, simple mental health education. Like, when we start doing this work, let's really talk about what mental health is and give you a working definition that hopefully makes sense to you. I'm not gonna tell y'all right now because we ain't got time for that. But just that the whole experience within itself was such a beautiful experience. After we finished, we threw like this big celebration, invited like the whole community to come, and we shared all the information we collected, and we shared our findings, and then we shared our recommendations, and then we gave everybody access to this information, which I don't know. I'll give somebody that information. It's still out there and available to everybody. There's so much more that maybe I could say later. I feel like I could talk for hours about
That's good.
the Kapasa Fitu project, but we definitely did. We're trying to tell the stories that aren't being told in the data already out here right now.
Thank you so much. We have both of the community needs assessments, actually, both of you all. So we're happy to share those out because there was so much to unpack from what you both just said. I feel like I'm like having a hard time real-time processing, but just around like how you reach communities. The length of that project too, I remember reading it, it's not that long. It was like a year or so, yeah? One of the things that has always bugged me is when people describe our communities as hard to reach. This happened during COVID a lot, and I'm like, hard to reach for who? Because you can reach them, right? I mean, you can reach our communities if you know how to do it, and there are models up on stage of how you do that. Annie, I have a question for you that is about some of your work in this mental health space. And this is not on our list, so forgive me. But it's, you talked a lot about kind of the role that self-help for the elderly has been playing in the mental health space. Can you share some observations of, you've also interacted with systems, and you talked about like adult protective services. Sometimes that doesn't work for our communities. And I'm wondering if you could say a little bit more about that based on what you've observed in your work.
Yes. We all work with APS, right? And earlier, somebody asked, whether there are APS or other government kind of representatives here, and I saw some hands raised. So this is not a criticism of APS, but I think across the Bay Area, all APS workers are overloaded. They have too many cases. I don't know how many that they are carrying, but from the community perspective, when we see a senior in crisis and we reach out to APS, I would say our experience usually is they're not sick enough. And so in our mind, how do you define what's sick enough? Because this one client of ours is suicidal and has been suicidal. I share the case a little bit, which I want to share with all of you too. Have been suicidal for weeks and weeks and weeks, to the extent that she solicited help from relatives, friends, management staff, property managers where she lived, as well as the handyman, to see if they would help her go through to commit a suicide act. And none of them, including her caregiver, is willing to be part of her plan. And as a matter of fact, we got her case through her caregiver. She quit because she's worried that she'll be part of her employer when she actually would want to commit suicide. So when we got the case, of course, we reached out to APS, and they said make wellness check. They call, I guess, and then they called back and said it's not sick enough. She's not sick enough. And then ended up, we have to also call the police about 5 times. And the police went, and every time similar. Oh, the elderly is okay. She says she's not suicidal. Of course, the client said she's not suicidal. And ended up my case manager, my senior case manager, have to pretty much, like every day, every night, make sure how she's doing. And actually, she started out having a neck problem, like her neck's not feeling well. But somehow she thought that if she went into the hospital, then she would die in the hospital, and she would not want to do that. She'd rather die at home. And she wrote her will, she planned everything, put it in the drawer, and all she needed is somebody to help her. But that didn't happen, right? Nobody around her wanted her. So finally, there was one incident that APS would not go out. The police went and came back and told my social worker that she's okay. But we know she's not okay. So we make one more attempt to a wellness check by the local Central Police Station. They took her into the hospital. She was there for 72 hours, but they found, the cause of her neck problem. Somehow persuaded her to stay longer in the hospital. She got well. Her neck was not, dropping down. And then she no longer expressed the wish to die. It was that simple. It was that simple to us, right? But if nobody from the public sector can go out and make a deeper assessment and really provide some immediate services to do something, that elderly could have just gone through with her original plan. And it would be a very, very sad incident if that happened. So when I look back to kind of a crisis like that, we now, meaning at self-help and other CBOs who are not mental health providers, have to prepare our staff to handle situations like this. And then you also need to have somebody to call, right? So for me, I mentioned earlier that that there's a group of retired social workers, LCSWs, and also psychologists that are willing for me to call, like at 9 o'clock, 10 o'clock at night. In a crisis, I say, what do we do? APS said, not sick enough. We send the police out and they say, elderly is well, is fine, right? She's not suicidal, so would not 5150 her. And then I get some kind of a consultation. And I think we need to have people that are willing in the community to really do that sometimes at the drop of the hat, because the crisis is happening and we need to do something. So I think that's another way to look at it is we find our own solutions. And many, I think in the CBO world, we have to innovate and be creative, and our social workers need to be trained to also be creative. If we stick to the book and say only the APS workers or the police could 5150, and the elderly are not willing to go into the hospital, what do? You still have to find that 24/7 kind of a resources to make sure that the senior is okay and that you are there for her. I think that when the senior knows that we are there for her, she could call us, and then we beg the caregiver to go back to work for this elderly because we are supporting the caregiver, and that at any time they call, we could step in. So I think that saved the elderly's life. Yeah.
When Annie first shared that story with us, Annie, you said on our prep call, you said, the care worker who was supporting this person was actually the woman was not a client of self-help for the elderly, but the care worker was trained through one of the 15 programs that Self-Help for the Elderly runs, right? To train in-home care workers. And so that was sort of a lucky thing, right? And you shared, Annie, that you said on our call, we all wrote this down, like our work cannot depend on miracles, right? Our work cannot depend, in this case, on the happenstance that this person was supporting this woman and had the wherewithal to call self-help for the elderly. But that's what we're operating off of right now, right? And so I just want to really highlight, and you're hearing it from all three. I mean, all three of these organizations are deeply entrenched in community in different ways, and they're being asked to play this role and carry this load around supporting mental health in ways that, quite frankly, are not compensated and maybe not even seen. So I just want to really appreciate all of you for that. I'm going to do a quick time check. We've been until 2:30, right? Okay. I'm going to ask one more question, and then I'll open it up, okay? Because, so we talk a lot about, we've been talking a lot about, how do we define mental health and well-being? And for each of you, you've all entered into this space in different ways with mental health programs. You may not call it that, right? Because that's not what's going to draw our community in. But we've been talking a lot this morning around, like, what does effectiveness look like in our communities? What does mental well-being look like in our communities? And I'm wondering if you could say a little bit about that. As based on your work, right? What are the outcomes that you want to see? What are the outcomes that you're striving for in your work? Anybody can start. Take a minute.
Carolyn, if you ask me what wish, what's our greatest aspiration, I always thought that many years ago, over 10 years ago, our federal government said, let's integrate physical health with mental health, right? Let's have a holistic approach. 15 years later, I'm still waiting for that to happen. right? It's not never happened. The physical health side, kind of like a silo, mental health. Yeah. Now, if we know each other, then we work together and provide that holistic approach to health, right? And I think that's my wish. I think that a little secret, to share is many years ago, 25 years ago, I went to the county mental health, and they have a wonderful LCSW. I call him Rudy. And Rudy, I said, I cannot send my clients to you. They would not go into a mental health clinic. But you could come and be a social worker among my staff. We don't pay you, LCSW. You're still paid by the county, right? But I will introduce you as our staff. And our seniors love Rudy. They would line up to go talk to him and have an appointment with Mr. Kao and Go Xin Sang, yeah. And that's the approach I would like all of us to be able to do, is somehow bring in the mental health professionals that many of you are, but bring you into a more community-based, kind of a client-centered setting, and no labeling of mental health anywhere. But if you're lonely, if you're a little sad, there's Rudy to talk to you. Yeah, that's my wish.
Oh, let's give it up for Rudy.
Yes.
That's amazing.
Retired.
Yeah, I think that's so, so beautiful, being able to just access that at any time. I felt very moved by your question of how we measure success, because for sure, every year we will measure the number of people who go through a program. We'll measure where they are at the beginning, where they are at the end. We'll see if they have feedback for us. But to be really honest and answer your question of what success looks like building a different world. Success looks like dramatically transforming the conditions that our people live in. That is what success would look like when it comes to mental health for us. With this question, I think about this year is our 20th anniversary as an organization. And so I'm very much like looking back into our history and kind of in that space. And I think about one of our elders who, when we changed our name to Lavender Phoenix a few years ago, she was telling us the story of our namesake, Phoenix Rising, a newsletter created by this amazing group of lesbian Asian women in the Bay Area back in the 80s. And she was telling me about how during the height of the HIV/AIDS crisis, she spent all of her time nursing and supporting her friends who were sick, who were dying, and who were being refused even acknowledgement, much less support, much less than support by the systems that existed. In a world that brings our people crisis after crisis every day, lasting mental health results are not possible. It's just impractical to believe that they are. So right now with Lavender Phoenix, we do have these mental health specific programs, but we're also looking at the balance of power, where power is, where money is spent in the Bay Area, in California. Just last week, for folks who are living in San Francisco or who work in San Francisco and pay attention to San Francisco, you probably saw that we're facing tens of millions of dollars in cuts to community organizations, nonprofits, and social services. That exact amount, more than that actually, is going straight into the SFPD, bringing the budget of the SFPD over $800 million. That's $400 million, more than similar-sized cities across the country. What this means, I promise you all, is that we will see the results of that budget in the mental health surveys, in the well-being and livelihood of our children's lives 5 years, 10 years, 15 years down the road, because it's coming out of the programs and the schools that our people need. So I will say that if we are not challenging power, if we are not building the ability of our communities to have a say in governing, if we're not deepening relationships that keep us strong even when systems fail us, we won't be able to be successful. We need to do those things if we want to give our people a chance to win.
Period. Yeah. Yeah. So this question is so hard to answer. You know, the outcome we would love to see is that we're not doing this work. That, you know, our people are thriving, surviving, not surviving, just thriving, right? Living life, feeling joyful, right? And I know that sounds woo-woo, but we deserve that.
I have more questions, but it's fine. It's fine. I'll hold back. If folks have questions in the room, I think we've got, thank you, Alan, running a mic, and then there's also a mic here. So just welcome folks to come up and ask a question or raise your hand if you have questions. Did I see one back there, Tara? No? Okay. Oh, yep. Sorry. We're getting our steps in. Thank you.
I don't want to be an ableist. So, hi, my name is Ella, and I am from the California Healthcare Foundation. And some of the things that I heard, I feel like a lot of this work was volunteer work and working formally in nonprofit and grassroots. I was burned out. So I'm curious, what does funding look like for your programs? Where does that come from? And if you had unlimited funding, how would that change, like what you would want?
Unlimited funding. That's music to our ears. I think we really need to think long term. How do we cultivate or encourage our young people to go into mental health, particularly if they are bilingual and bicultural, you know? There seems to be not a whole lot of interest in that area. Yeah. So we're looking for bilingual therapists, but they're out of town, and then telehealth is so expensive, you know. So if I have lots of foundation resources, then I would love to add a couple of mental health professionals on my staff, but I know that that's not going to happen. Yeah.
I have some takes on this question too. I think for me, a former health funder too, right? So I'll just put that card on the table. But I think as I've interacted with our affiliates who are doing this work, there is so much that they are doing that isn't attached to a reimbursable code. And yet, clearly, the work that they're doing has value in terms of lives saved, but also well-being, right? And health, right? And so I think how we quantify and value some of these services that are often invisible, right? The calls that Annie's caseworkers get, they're not behavioral health support staff. They're caseworkers. They get calls, our Half Moon Bay response, right? Annie, they're getting calls 24 hours a day. She can't bill for that. That's not getting paid for, right? And so I do think there's a need to shift the way that we look at the services that are being provided outside of the boxes and the codes and the categories that are reimbursable, and value all of this work that is uncompensated, right? I mean, from formal systems, but I think as funders, this is infrastructure. This is infrastructure for, you know, they're responding in times of crisis. They don't get continued funding. They're not gonna be there to respond the next time, right? So I think there's just a lot in terms of challenging our notion of, that's why I asked the question of outcomes. It's not about counting visits in or out. That's wrong, right? It's fundamentally flawed for a lot of reasons. But how do we reevaluate what positive outcomes are? But first, they need to be voiced on the stage about what those outcomes need to feel and look like. And then we need to attach value to that. But I'm not a panelist, so sorry.
Yes, you are. Yes, you are. You know, that's so funny. If we had unlimited funding, then we would all be back in the islands right now. We're going all back to the islands. So, but the other thing I was just thinking about, that I was going to say for real, but I was being for real when I said it. I am being for real when I say it. But I was just thinking about like billing. I heard you talking about billing, and right now at SCDC, at the Samoan Community Development Center, and at the Pacific Islander Wellness Initiative, which Brother Kevin was representing earlier, you know, our therapy services are grant funded, and so they're free, right? And so you don't have to diagnose. You don't have to come up with a diagnosis to bill Medi-Cal, you know, and then do all that paperwork, right? And that stuff, that billing in general is a barrier to just really thinking and talking about and experiencing and cultivating healing. You know, these systems are a source of great harm. And so, you know, like for myself, you know, and I could say this like publicly because I said it to Patsy, our executive director, many times, that I'm not doing Medi-Cal billing. I refuse, you know. I will leave. I'm leaving. I ain't doing Medi-Cal billing. So we better keep finding that money to make this free, you know. And it really comes down to like sustainability, you know, because money is just always here and then it's not, and then it's here and then it's not. Well, can we just keep it here so we could keep it going, you know, and not feel like taken for granted, you know. And, you know, just, you know, and that really is about accessibility. And, you know, I'm representing, you know, the Samoan and Pacific Islander community, but really this is about our humanity and what we all deserve access to. And there's nothing innovative about accessibility. There's nothing innovative about that. We all deserve care. And care is free, and it should be free. It shouldn't be commodified. It shouldn't operate under a system of capitalism.
Hi, my name is Angie Jin. I'm from Kaiser. So my question for you is, if you want every single table, every single audience commit to do one thing today, what would that be? So I would like to have all of us to take one action home and support you all. That's it.
The pandemic has caused a lot of issues among the elderly because of isolation, right? Imagine even for yourself that after 4 years, if you don't get to see a lot of your relatives, friends, you know, neighbors, and you stop going to church or whatever because you're afraid, something you know shifted. So I would say if every one of you will call one of your elderly relative or church member or friend or neighbor and make sure that they know that you care and you love them. Yeah.
Hello? Yeah, thank you for that, Annie. Yeah, you know, I think that one of the greatest misconceptions that people have about transgender and queer Asian and Pacific Islander communities is that our communities are niche. Is that because those identities sound very specific that, oh, that's just a tiny, tiny wedge of all of our people. But actually, trans, non-binary and queer, Asian and Pacific Islander people are at the front lines of every single health-related issue that everyone in this room cares about. So I think if there is one thing that I would ask folks to do, it would be in the realm of understanding. And I would really encourage folks to go home and read the needs assessment that SCDC put out, read the needs assessment that our members created up to us, and also learn more about self-help for the elderly. Yeah.
Yeah, I would echo what's been said already. Then I say just go home, feel what you feel, give yourself grace, and rest. Get some rest. Do something that makes you feel happy.
I also will just say real quick too, in additional things to, I'm going to plug the sign-up sheet that KCCEB is circulating around the Alameda County action. If folks want to take that kind of action, the sign-up sheet is still there. I also want to take a moment to recognize, it was mentioned, I think Amy mentioned it in the morning, many of us in this room are part of a health equity coalition, statewide coalition. If folks are part of that, do you mind just raising your hands? If you're a part, I know I'm looking at some of you. I'm like, yes, to raise your hands. You're part of it, too. I'm like, I just want to recognize them because these are folks who've been working in the background for months on our behalf. Around mental health. There was a hearing that was yesterday in Sacramento that folks spoke at. We'll send around the recording to that. KCCEB played a huge role, as well as Natalie, who was here early for the PI task force. So those are also things that I would say encourage you to look at and share. Because share it amongst your networks and get it out there. The other thing is, I don't think this is lobbying. Well, I'm not going to say this is lobbying. But, well, it is lobbying. Less than 10% of my time a month. Next Tuesday in Sacramento, we have a language access bill that this coalition has been championing. It's passed through the Senate, and it's going to be heard in the Assembly next Tuesday in Sacramento. So we'll send out information on that, too. If you have friends in Sacramento, to please show up. We were able to get like 100 people there. There were 50 people there yesterday for the mental health hearing. So these are also ways that you can take action, in addition to what our lovely panelists have highlighted. I think we've got maybe time for one more question. We got
Hi, I'm Emerald Ye on the board of the Asian Pacific Fund. And so this question is to our affiliates, but the panelists can answer on their behalf. But can you talk about the importance of the mental wellness, the well-being of your staff? You know, the staff and the caregivers for nonprofits, because they're on the front lines working outside of their role, dealing with mental health issues that are not labeled as such. And my understanding also is that a lot of people are on the staff of these nonprofits because they experience some of the same traumas and issues and have that empathy to not make a great living, to be tending to others. So I'm curious as to your thoughts as to the mental wellness needs of your staff.
Yeah, this is off. Hello, can you hear me? Hello? I'm just gonna keep talking. Okay. Thank you for that great question. Yeah, you know, you're absolutely right. You know, myself and our previous executive director, we both came into our organizations through the youth program in the organization. So the organization has seen us from that youth program all the way towards our current or past roles. And I didn't come to the program as a young person because I wanted to be the ED of an organization. I came into the program because I was extremely lonely, because I lived in New York City at the time, and I was afraid to go on the subway because the way I dressed would, you know, attract violence and harassment. And I didn't know anybody who was like me, who I could connect with. And when I found Lavender Phoenix, it felt like medicine for that. So I think, you know, your question of how do we take care of our staff people, how do we take care of each other, I think it shows up in the culture, but also in the structures of our work, right? Like, absolutely, I think it's probably apparent to all of us that in the culture of the work, we should strive to be caring, we should strive to be mutual, we should strive to be interdependent and supportive, but also in the structures of our work, can we reflect that as well? When I joined the organization, we didn't have the financial resources, like you said, to pay our staff very well. Thankfully, over the last few years, shout out our deputy director, shout out other folks in our staff who have been able to help us get to a more secure place. We've been able to increase the base salary of folks at our organization almost 100% from our previous ED's time to right now. And we've also been able to decrease the difference, the gap between the lowest and the highest paid person to under $15,000. For us, those are structural decisions that make sure that our staff, yes, they're working on something they care about, but they're also not doing so every single day in a way that sacrifices their livelihood, and also in a way that, in a way that sacrifices their well-being. So those are some things that we're experimenting with and trying.
Emerald, thanks for asking that. As the CEO, we're always looking for money, right? We continuously, 24/7, do fundraising. But really, we have to start to think about, like Yuan say, some structural improvement to our benefits, salary, as well as what do our staff need? Because we keep piling on their plate when we are so understaffed now. I don't know if a lot of you share the same concern. We just cannot hire people or hire enough people to do the work. So the existing staff are very burdened, I think. And as a management staff, we have to make sure that we make time for them. So for us, we're trying to introduce some meditation session. We give each of the departments some extra money so that they could take their staff out for lunch or whatever, on a regular basis. And our benefits do provide counseling if the staff need it. So all those are some infrastructure, little change, doesn't cost a lot of money, but I think that it would go a long way to help staff to also provide self-care for themselves. Yeah.
Yes, I agree. I think we at SCDC we've been working to shift how we think about doing the work. And so when we do the work, it's like, let me help you, or you should do this, you should take care of yourself, right? But it's a we thing. It's a we thing. So it's you take care of yourself, and I'm gonna take care of myself too. So, you know what I'm saying? And so it's like, how do we take care of ourselves? How do we talk about mental health? How do we cultivate healing, joy, happiness? That's a shared experience. And we're not telling you to do anything that we're not trying to do either. We're not telling you to do something that we're not trying to make space to do for ourselves either. And so that's a very kind of a shift in how we see doing the work that's driven by the way we anchor ourselves and how we move with intention in the way we do the work. And then there are some system things around like what we're paying people, how much time they're getting off, right? And so when I said earlier to rest, right, that's not to run away from all the stuff that's going on in your life. It's to say that, man, we spend 40 hours at minimum a week working. That's normal. That's our baseline. And that's a lot of time. And there's many, many, many people working more hours than that. Right? And when you're in the work of doing service work, I think of all our Pacifica people. I started with the proverb around service. We're service-oriented people, and so are we serving ourselves as well? Are we included in that service? Working among Pacifica people for the Pacifica community is also like, we're a part of that community too, so how do we get access to some of these services too? You know what I mean? And so it is that shift from I or you to we, and that we're in this together, and we gotta be looking out for each other as we do this work.
Please join me in thanking this amazing panel. Yuan, Anni, Tone, thank you so much. Thank you. I believe there might be sweets.